The endocrine system is composed of multiple glands that play a vital role in things such as orchestrating cellular interactions, metabolism, growth, reproduction, and response to adverse conditions. When we look at some of the different glands, the hypothalamus, which controls the release of the pituitary hormones and controls things such as body temperature regulation, hunger, thirst. The pituitary gland, often referred to as the master gland of the endocrine system, this plays a vital role in controlling things such as the thyroid, the adrenal glands, ovaries, and testes. The anterior pituitary gland secretes the thyroid stimulating hormone, or TSH, where the posterior releases ADH and oxytocin. The two main glands that we're going to focus on in this lecture are the thyroid and the parathyroid. The main function of the thyroid gland, which is the largest endocrine gland, is to control cellular metabolic activity. The thyroid gland can be found anterior to the trachea and is often referred to as the butterfly gland, as its shape has a butterfly origin. The three main hormones produced by the thyroid gland are T4, T3, and calcitonin. The secretion and production of T3 and T4 is regulated by the TSH, or the thyroid stimulating hormone, which is produced by the pituitary. These amino acids contain iodine atoms and assist in controlling metabolism. T4 contain 4 iodine atoms, where T3 contain 3. Calcitonin is another hormone which is produced by the thyroid, and this helps to maintain equilibrium in the amount of calcium in the body. It is secreted when there is high levels of calcium found in the bloodstream, and it helps to reduce the level by increasing the deposition of that calcium back into the bone. The thyroid gland relies heavily on iodine, as this is needed for the synthesis of hormones T3 and T4. Iodine is absorbed into the bloodstream through an individual's diet from the GI tract. When we look at the thyroid stimulating hormone, or TSH, it uses a negative feedback mechanism. And simply this means that when there is high levels of T3 and T4 in the bloodstream, the thyroid stimulating hormone is decreased. Whereas when there's low levels of T3 and T4, the pituitary increases the secretion of TSH. And this is done to maintain equilibrium. When doing a physical examination of the thyroid gland, the client is asked to extend their neck slightly and swallow. The thyroid normally rises with swallowing and can be palpated at this time. When looking at diagnostic evaluations, as I mentioned on the previous slide, a serum TSH is the primary screening test for thyroid function. TSH can be used for monitoring thyroid disease and also monitoring the effectiveness of hormone therapy. An iodine uptake test looks at the uptake rate of radioactive iodine by the thyroid gland. Iodine is given to the client and values are checked a few hours later. A high uptake of the iodine could be an indication of hyperthyroidism. Needle biopsies may be performed to obtain a sample of tissue if detecting or screening for any malignancy. Nursing implications, we would want to be sure to ask the client about any allergies to iodine or shellfish. and whether the client has taken any medications that contain iodine, because these could alter the results of any diagnostic evaluations. Hypothyroidism is a disorder in which there are suboptimal levels of the T3 and T4 thyroid hormone. When looking at the causes of hypothyroidism, the most common is Hashimoto's, which is an autoimmune disorder in which the immune system attacks the thyroid glands. Another cause of hypothyroidism may be if the client was previously treated for hyperthyroidism. They may have been overtreated with medications or had a thyroidectomy, which then led to hypothyroidism. Another cause may be a dysfunction of other various glands, which can be broken up into primary and central hypothyroidism. Primary hypothyroidism is a dysfunction of the thyroid gland itself. Central hypothyroidism would be a malfunction of either the hypothalamus or the pituitary gland, or both. A malfunction of either one or both of these glands can negatively impact that negative feedback system that I was talking about on the previous slide with the release of the TSH hormone. Looking at the clinical manifestations, these clients often complain of extreme fatigue. They have hair loss, dry skin. Really, everything in their body starts to slow down. So we'll see a decrease in their heart rate, a decrease in body temperature. These patients will complain of weight gain, although their appetite has been decreased. Some mental effects we'll see are things like a dull, blank expression or slowed speech. The most common age group that is affected of hypothyroidism is women between the ages of 40 and 70. They may also complain of feeling cold all the time, constipation. The respiratory system is oftentimes affected as well, as the weakened respiratory muscles can lead to inadequate ventilation. It's important to remember that these clients will be very sensitive to opioids or any type of anesthesia. Myxedema coma is a life-threatening condition in which the body is severely decompensated from severe hypothyroidism. Some of the causes may be from undiagnosed hypothyroidism, a client who is non-compliant with their medications, or the use of sedatives if the patient has gone in for any type of surgical procedure without proper management afterwards. Some of the signs and symptoms we'll see is at first the client will present with a diminished cognitive status, and if untreated, the client may become lethargic. There's a severe respiratory depression, and the respiratory drive is suppressed, which would lead to an increase in carbon dioxide retention from hypoventilation. There will be a decrease in body temperature. The client will be hypotensive, bradycardic, and hypoglycemic. They may start to present with signs and symptoms of shock from the cardiovascular collapse. Treatment is emergent, and these clients must undergo aggressive hemodynamic therapy to improve that cardiac output. When treating a client who has hypothyroidism, our overall goal is to restore a normal metabolic state by replacing that missing hormone. Levothyroxine or Synthroid is a medication that is given for hypothyroidism or the suppression of any goiters or enlarged thyroid. It is a synthetic form of T4, which then would be converted to T3 within the body. This medication is based on TSH concentration levels and is given orally. In an instance of myxedema coma, it can be given IV in emergent situations. We would want to educate the client to report any signs or symptoms of insomnia, palpitations, or tachycardia, as this may indicate that the dosage is too high. When we're treating somebody with hypothyroidism, we also want to frequently assess their cardiac function. These individuals are at a high risk for high cholesterol, atherosclerosis, and or coronary artery disease. And what happens usually is when a client has hypothyroidism, their cardiac system is usually affected. However, the patient at first is usually asymptomatic because when they're in a state of hypothyroidism, their metabolism is low, and these patients require less oxygen to the tissues to begin with. However, issues start to arise when oxygen demand increases and that hypothyroidism is fixed. At this point, the body can't meet the oxygen demands due to the coronary artery disease or atherosclerosis. So once we fix that hypothyroidism, then the patients start to become more symptomatic. They may have things like angina or dysrhythmias. In this sense, we would want to slowly increase the levothyroxine dosage to reach therapeutic levels. Looking at medication interactions, we want to be very mindful if the client is on any blood thinners, as this can lead to an increased risk of bleeding when they were also taking levothyroxine. As far as nursing management, we want to educate the client on the effects of any sedatives, as these are prolonged within the body. When providing our plan of care for these clients, we want to be mindful that these clients are at risk for things like activity intolerance, constipation, ineffective breathing pattern from a decreased ventilation, or imbalanced body temperature. Hyperthyroidism, on the other hand, is an excessive secretion of the thyroid hormones. The most common cause of hyperthyroidism is Graves' disease, which is an autoimmune disorder that results from excessive output of the thyroid hormones. Women are much more commonly affected than men, and although the exact cause is unknown, Graves' disease often occurs after any emotional shock, infection, or stress. Other causes may be a toxic adenoma or benign tumor, or we may also see this after a medication noncompliance, or if a client ingests a large amount of thyroid hormone, such as levothyroxine. A client with hyperthyroidism often complains of not being able to sit still and is very nervous. We may also see things such as tachycardia, even when the client is at rest. They will complain of palpitations or have dysrhythmias, especially AFib is a common one seen. This would then increase the client's risk of any blood clots and decrease cardiac output. If left untreated, this could result in heart failure, which would then lead to localized edema in the lower extremities. The client may also have increased sweating, tremors, which we see especially in the hands, diarrhea, exophthalmos, which is also refers to as bulging eyes, The client often complains of extreme weight loss or muscle wasting, although they've had an increase in their appetite. Lab findings, which we would see if we were to do any blood tests, the client would have an increase in their T4 levels and also an increase if they were to have a radioactive iodine uptake test performed due to the hypermetabolic state. However, these clients would have a decrease in their TSH as the pituitary is trying to maintain equilibrium and reduce the amount of hormones that are released by the thyroid gland. When treating a client with hyperthyroidism, our goal is to reduce the thyroid hyperactivity and prevent any potential complications. Pharmacological therapy is used to inhibit thyroid hormone synthesis or hormone release. Medications such as methimazole or propofol are used to block the conversion of T4 to T3. We want to educate the client to take these medications 30 minutes before food in the morning to avoid any decrease in the absorption of the medication. We also want to educate the client to get a CBC and liver function test before starting these medications, as these medications can cause neutropenia or thrombocytopenia. Another type of medical management that is very commonly used is radioactive iodine therapy. In this case, the client is given a dose of radioactive iodine, which is used to destroy the thyroid cells, since the majority of iodine is retained in the thyroid gland. We want to provide a lot of education for any client that undergoes this type of iodine therapy. It cannot be used on pregnant women, so a pregnancy test should be performed prior. And we also want to educate the woman that she cannot conceive for 6 months after to avoid any potential complications. We will also want to educate the client on not sharing any utensils, as this can be, the radioactive can be passed through saliva or urine. We also want to tell them to avoid any close contact with children or women who may be pregnant. We also want to be very mindful for anybody who undergoes radioactive iodine therapy for the potential of thyroid storm. Thyroid storm is a condition that can occur immediately after the radioactive iodine therapy, and it can be due to the acute release of thyroid hormone from the irritation of the radioactive iodine on the thyroid gland. And what may happen is a large amount of thyroid hormone may be initially released. The client would experience things such as high fevers, extreme tachycardia, palpitations, and altered mental statuses. We would want to treat these. So beta blockers may be used to help with some of the cardiac issues. The client may require a hypothermic blanket if they have extreme elevations in their body temperature. We also may need to supply the client with oxygen to meet the metabolic demands, and IV fluids with dextrose to replace any fluid from the extreme sweating or diarrhea that may initially occur during thyroid storm. Some of the nursing management for a client with hyperthyroidism is we want to improve their nutritional status due to the weight loss and muscle wasting. So we want to educate them to have high calorie, high protein meals frequently, replace any fluid loss. A thyroidectomy which involves the removal of about 5/6 of the thyroid tissue, was once highly used. However, is now more frequently reserved for pregnant women or patients with large goiters or patients who are unable to take anti-thyroid medications for a long period of time. Prior to surgery, if able to, the client will be treated with anti-thyroid medications until the symptoms of hyperthyroidism have disappeared. They may also be treated with beta blockers to reduce heart rate and other cardiac symptoms that they may be experiencing. It's very important during the preoperative state for the nurse to educate the client on proper technique for supporting their neck post-op. This would include raising the elbows and placing their hands behind the neck to provide support and reduce strain and tension on the neck muscles. In the post-op period, oftentimes these patients are started on IV fluid due to the decrease in PO intake. And then once they're able to start eating more, we'd want to encourage high-calorie, soft diets to promote weight gain. In the immediate post-op period, the nurse is frequently monitoring for any post-op bleeding. We would monitor things such as a decrease in blood pressure or increase in heart rate, which could indicate this. We'd also want to educate the client to report any sensation, any increased sensation of pressure at the incision site. That this may indicate a hemorrhage or hematoma is forming. We also want to encourage very little talking in the post-op phase to reduce any edema. But we would want to immediately report any voice changes, as this could indicate injury to the laryngeal nerve, which is directly behind the trachea. We are constantly monitoring for any respiratory distress, as this could indicate a post-op hemorrhaging or hematoma formation. It's extremely important in the immediate post-op phase to have a tracheostomy kit at the bedside. We also want to monitor for any parathyroid damage, which can cause disturbances in calcium levels. So we would be monitoring for signs of tetany or hyperirritability of the nerves that we would see in an alteration in calcium levels. Along with a tracheostomy kit, we also want to make sure that IV calcium gluconate is also at the bedside if there is any damage to the parathyroid glands and calcium levels. The parathyroid glands are located on the posterior aspect of the thyroid gland. An individual normally has 4 parathyroid glands. The protein hormone produced by the parathyroid glands is called parathormone. This is used to regulate both calcium and phosphorus metabolism. An increase in this hormone secretion leads to an increased calcium absorption from things such as the kidneys, the intestines, and bones, which would lead to an increase in serum calcium levels. Parathormone can also be used to lower blood phosphorus levels. And just like we talked about with the thyroid gland, the amount of parathormone released by the parathyroid glands is based on a negative feedback system, meaning if there are high levels of calcium in the bloodstream, there would be a decrease in the parathormone secretion and vice versa. Hyperparathyroidism results in an overproduction of the parathormone. The main causes of hyperparathyroidism can be classified as either primary or secondary. In primary hyperparathyroidism, issues originate in the parathyroid gland itself, leading to an oversecretion of the gland. Secondary hyperparathyroidism is due to kidney failure. What happens is with an individual with chronic kidney disease, they have high levels of phosphorus, which causes a secretion of the parathyroid hormone to help lower the phosphorus levels within the bloodstream. So the body is trying to compensate. Either way, whether it is primary or secondary, clients who have hyperparathyroidism suffer from bone decalcification or bone softening from the calcium being pulled out of the bone. From the calcium being pulled out of the bone into the bloodstream. And oftentimes also suffer from renal calculi containing calcium. Other clinical manifestations you'll see is extreme fatigue, bone fractures, especially in the weight-bearing joints, constipation, irritability. Think about all the signs and symptoms that we would expect to see with somebody with hypercalcemia. Diagnostic findings would show an increase of serum calcium levels. X-rays would show those bone changes, as I mentioned. A double antibody parathyroid hormone test looks at the parathyroid hormone level and calcium level. This is used to determine primary versus malignancy. A needle biopsy may be used if there's any cysts or adenomas on the gland. The management of hyperparathyroidism really depends on the severity of the disease itself. In mild cases, most oftentimes the physician will monitor the client closely for any disease progression. However, in more severe cases of primary hyperparathyroidism, surgical management will take place and a removal of the abnormal parathyroid tissue. As far as the nursing management, we want to educate the client on the importance of staying hydrated. And oftentimes, these patients are encouraged to have up to 2,000 milliliters a day due to their high risk of developing renal calculi. So it will help the formation of these kidney stones. We'd also want to make sure that they are taking no thiazide diuretics, as these medications decrease renal calcium secretion, which would cause an increase in calcium levels in the bloodstream. As far as mobility, we want to encourage physical activity as much as possible, as we know bed rest leads to even more calcium excretion from the bones. As far as diet, we want to educate the client to avoid foods high in calcium, such as cheese, milk, spinach, orange juice. And we also want to encourage them to have things such as prune juice or take stool softeners and stay very hydrated to prevent any potential constipation, since they're at a very high risk for constipation. Untreated hyperparathyroidism can lead to a hypercalcemic crisis. And this is when serum calcium levels rise above 13. This can cause severe neurological, cardiovascular, and kidney complications. In this sense, the client is emergencyly treated with large amounts of IV fluid. As a nurse, we'd want to be monitoring for any fluid overload. And they would also be treated with calcitonin, which is a medication that promotes renal secretion of calcium. Hypoparathyroidism is caused by an inadequate secretion of the parathormone, leading to decreased serum calcium levels. We can also see this in clients that have a vitamin D deficiency, as we know that vitamin D helps with calcium absorption within the body. The most common cause of hypoparathyroidism, though, is from any type of surgery on the thyroid gland after a thyroidectomy. And if you remember on the previous slides, I talked about the importance of having IV calcium gluconate at the bedside after a thyroidectomy. And this is due to the potential of hypoparathyroidism occurring after a removal of the section of the thyroid gland and the parathyroid being affected as well. Serum levels, as I mentioned, would show a low calcium level and a high serum phosphorus level. Clinical manifestations would be things that we would expect to see with somebody with hypocalcemia, such as tetany, anxiety, irritability. They may have some numbness or cramps. X-rays would show bone with increased density. The management of hyperparathyroidism really is determined based on the underlying cause. Medications such as calcium or vitamin D may be given to increase calcium levels by helping with the parathormone release. We may also see thiazide diuretics given, since these help to decrease calcium secretion. Some of the nursing management, we want to closely monitor the client for any respiratory distress from any neuromuscular irritability or bronchoconstriction that we will see with somebody who have low serum calcium levels. So it would be important to make sure that you have a tracheostomy set nearby if the client is experiencing any bronchoconstriction or severe hypercalcemia respiratory distress. As far as education related to their dietary, we want to educate these clients on high calcium diets. However, we want to make sure that these clients understand that things such as milk and eggs are also high in phosphorus, so we'd want them to avoid these foods. Aluminum carbonate may be given with meals. These help to bind phosphorus and promotes excretion of phosphorus through the GI tract. If you refer to the pictures over on the right-hand side of this slide, you can see that the adrenal glands are positioned on the upper portion of each kidney. If you then look below, if you were to look inside the adrenal gland, you can see that there are two separate independent functions within each adrenal gland. The adrenal medulla is part of the autonomic nervous system and works with those functions that release epinephrine and norepinephrine and works with our fight or flight hormones. The adrenal medulla is responsible for increasing basal metabolic rate, elevating blood sugar, and promoting catabolism. This would include the breakdown of muscle protein to amino acids or the breakdown of fat. The adrenal cortex is responsible for things and influence things such as glucose metabolism, electrolyte metabolism, especially that of sodium absorption or reabsorption, and also impacts the sex hormones. Addison's disease is another disorder that originates due to complications within the adrenal gland. Addison's disease occurs when either there has been damage to the adrenal glands or the adrenal glands cannot produce sufficient amount of cortical hormones to meet the body's needs. The majority of cases of Addison's disease originate from either an autoimmune disorder or idiopathic, which also means an unknown cause. Other causes may be after surgical removal of both adrenal glands, infections, the overuse or long-term use of corticosteroids, stress, or we may also see this when the pituitary gland has a decreased secretion of ACTH. ACTH is a hormone that is produced by the pituitary and stimulates the production and release of cortisol from the adrenal cortex. The adrenal glands are part of the endocrine system. So just like we had talked about previously in the thyroid lecture, the pituitary controls the thyroid gland and also controls the adrenal glands. Clinical manifestations that we would see are muscle weakness, anorexia and fatigue, hypotension. The patient may also have depression or confusion, a dark pigmentation around especially areas of the knees and elbows. And in more severe cases, they will have low sodium and high potassium. This low sodium will lead to dehydration. And the client may also have low glucose, so we'd want to monitor them for hypoglycemia. When we look at the serum lab values for somebody with Addison's disease, this can help us identify where the origin of the disease is originating from. If the disorder is originating from the adrenal cortex, the client will have low cortisol levels but a high ACTH as the pituitary gland is trying to compensate and continues to release high amounts of ACTH. However, since the issue is coming from the adrenal cortex, it is not responding to that negative feedback system, and they will continue to have low cortisol output from the cortex. If the client has Addison's disease due to a pituitary issue, then we would see low levels of ACTH in their blood work. As I mentioned before, when looking at lab values, we would also see values that indicated hypoglycemia, hyponatremia, and hyperkalemia. As we know, the adrenal cortex is responsible and influences glucose metabolism and sodium reabsorption. A client who is non-compliant with their medical management regimen for Addison's disease is at a very high risk for developing Addison's crisis as the disease progresses. If untreated, the client would start to show signs of confusion, hypotension, cyanosis, and this may even lead into circulatory collapse or shock due to the low fluid volume. Medical management of somebody with Addison's crisis requires immediate intervention. The primary focus would be to restore fluid volume and blood circulation by administering IV fluids, and we would also be administering corticosteroids. Most likely, the IV fluids would be that of D5 normal saline to help improve both glucose and sodium levels within the body. If Addison's crisis was brought on due to an infection, the client would also be treated with antibiotics. Education is extremely important from the nurse's end when caring for a client with Addison's disease. When looking at dietary habits, we want to educate the client on ways to not only restore, but maintain a healthy fluid balance. Since the client is at such a high risk for developing hyponatremia and hypovolemia, we want to educate the client on ways to prevent this from happening. We would talk to the client about avoiding humid weather, but if they were put in an instance where they were in humid weather or having excessive sweating, we would want to educate the client to increase fluid intake and also choose foods that are high in sodium to help prevent hypovolemia and hyponatremia from occurring. This would also be true for any instances of GI disturbances. If the client had any periods of diarrhea, we would once again want to educate them to choose foods that are high in sodium to help with the reabsorption of that water. Since both physical and psychological stress can greatly impact somebody with Addison's disease, leading to Addison's crisis, we want to talk to the client about avoiding extreme cold temperatures, overexertion, and emotional distress. Since this client will require lifelong replacement of the adrenal cortex hormones, we not only want to provide education to the client about their medications, but also their family members. The nurse should reinforce to the client the importance of taking their medication every day as prescribed by the physician. Oftentimes, these clients will have emergency kits in their home if they are starting to show any signs of Addison's crisis. These emergency kits contain corticosteroid pre-filled syringes that the family member would be able to administer to the client while waiting for higher medical attention. Med alert bracelets are often worn by clients with Addison's disease, and these would be useful to help alert EMS if the client was unconscious or lethargic, so EMS would know what was in the client's past medical history so they could properly treat them. Unlike Addison's disease that results from a deficiency in adrenocortical activity, Cushing's syndrome results from an excessive activity within the adrenal cortex. Due to the excessive output of the cortisol hormone, these clients, unlike Addison's disease, would be at an extremely high risk for things such as hyperglycemia and hypernatremia. With this hypernatremia, they are also susceptible to retaining water, which would then lead to hypertension and most possibly continue on to heart failure. Due to the chronic hyperglycemia, these patients have slow wound healing and most oftentimes complain of weight gain. One of the classic symptoms seen with somebody with Cushing's syndrome is the buffalo hump in the neck and supraclavicle areas due to the musculoskeletal changes that occur. The client may also develop a moon-faced appearance. And women oftentimes take on masculine traits due to the excessive output of those sex hormones. The medical management of somebody with Cushing's syndrome is really dependent on what the cause of the disorder is. If the cause originates from the pituitary gland and there is a pituitary tumor causing an increased secretion of that ATCH hormone, which then leads to an increased production of the adrenal cortex hormone, then management would be focused on the pituitary gland. The client would most likely undergo surgical intervention or radiation of the pituitary gland. If it was caused from the adrenal gland itself, the client would undergo an adrenalectomy. But we'd want to be very mindful that afterwards, in the post-op period, the client would be observed for signs and symptoms of Addison's disease due to a decrease in the circulating adrenal hormones. The client was used to having high amounts within the circulatory system, and now all of a sudden these levels would be greatly decreased. So we would start to monitor for the client to rebound and show signs of low blood pressure, low sodium, and low blood glucose. If the Cushing syndrome was a result of corticosteroid, we would want to make an attempt to reduce the medication or start to slowly taper the client completely off the medication to the minimum amount of dosage that they need to treat the underlying disease process. In some cases, we cannot completely take somebody off a corticosteroid if they have things such as an autoimmune disorder or some type of allergic disease. Since clients with Cushing syndrome are at such a high risk for muscle wasting and osteoporosis, we want to encourage foods that are high in protein, calcium, and vitamin D. We also want to be very mindful of these clients' skin integrity and frequently assess bony prominences and encourage the client to change positions frequently. We would want to avoid using adhesive tape due to the client's thin skin. We as nurses also want to be very mindful and include improving body images into our plan of care with the client due to the physical changes that occur for somebody who suffers with Cushing syndrome. Pheochromocytomia is a tumor that originates in the adrenal medulla and is usually benign. It is uncommon to see these tumors appear bilaterally, and usually the client will have a tumor on the adrenal medulla on only one side. This benign tumor stimulates the medulla gland, which results in large amounts of epinephrine and norepinephrine to be released. Due to the stimulation of the medulla gland, clients often present with what is classified as the 5 H's. This would be things like hypertension, headaches, hyperglycemia, hyperhidrosis, and hypermetabolism. Pheochromocytomia can be diagnosed using either a 24-hour urine sample or collecting a plasma blood test. You guys will not be responsible for knowing the diagnostic levels or even the normal levels. Really, what I want you guys to understand is the education that would go in, especially prior to collecting a blood specimen. Prior to collecting a total plasma catecholamine, we want to make sure that the client arrives 30 minutes prior and rests. What we don't want is any stress from the needle puncture or any exercise prior to the procedure altering the results. Really, what we want is to avoid anything that would create a release of epinephrine and norepinephrine prior, which would alter the results and give a false reading. The definite treatment for pheochromocytomia is a removal of that tumor, which usually results in adrenalectomy. Before surgery, we want to try to control the patient's blood pressure as closely as possible. So they may be started on a calcium channel blocker about 2 weeks prior. During the surgical intervention, we would closely monitor these clients for a hypertensive crisis. And this would be due to that stored epinephrine and norepinephrine that can be released during surgery, causing a surge of the patient's blood pressure and heart rate changes. Think back to when we did our thyroid discussion and we talked about thyroid storm and all of that being released during surgical manipulation. It's kind of the same thing with the adrenal gland being removed. However, afterwards, in the post-op period, the client may actually be at risk for hypotension and hypoglycemia due to the withdrawal of those excess catecholamines that they've been used to. Since the adrenal cortex is also removed with an adrenalectomy, the client may require steroid replacement. It may only be for a few days if they have just one of their adrenal glands removed. However, if they have a bilateral adrenalectomy, they may require steroid replacement for the rest of their lives. As far as nursing management, we'd want to educate the client on steroids and all the precautions of steroid therapy if they were to go home on them, especially educating them to not stop the steroids abruptly. They would have to taper off them. Oftentimes, these clients have urine or blood levels rechecked a few days after surgery to determine the success of the surgery.